no primary care, and every patient self-triages. So you woke up with a headache this morning. How about an academic neurosurgeon? Sounds like the first point of contact, doesn't it? Right. So there is no notion in China of right setting for the right care with the right person at the right cost at the right time. And of course, we've heard this in Israel too, that if you have an injury, do you want to go to your local hospital? No, you want to go to the top 10 hospital in the world, of course. Well, same thing happens in China. And that may be appropriate, but if you've got a, say, cough and a sore throat, do you really need to stand in line among 2,000 people at 7:30 in the morning to be triaged? You probably don't. So what does President Xi want to do? To exactly the comments you folks have made, if I take the healthcare experience of millions of patients over years and say, oh, it's April in Beijing and you have the sniffles, what do a million other patients have? What is the scope of disease you might encounter, and therefore what is the care you should probably seek? You know, probably not going to the academic medical center and standing in line for a few hours. Now I say there's cultural differences. So when I have been involved with this particular work in China, I ask some serious questions, as you all would, which is what are the privacy constraints, IRB approval, and say data governance frameworks we have to apply? And they all looked at me like, what? And so, you know, things in China move slightly fast. And so I said, well, how do you want to solve this problem? They said, well, you know, you're going to be here on Wednesday. I land at 5 a.m., by the way. I'll be in meetings starting at 8. And they said, well, why don't we just give you a tiny, tiny pilot? We're going to start with 1 million people, you know, tiny pilot. And we're just going to give you their lifetime longitudinal data, their genomes and everything. There's no consent, there's no data controls, and we're going to put it in normalized databases, see what we can learn, and if it works, then we'll go to 29 million people, the city of Shanghai, and then from there, 1.4 billion people across the country. So, national healthcare identifier, top-down command and control, no privacy concerns, and no data governance. So, I'm not saying that's right, but you can see how they are approaching transformation in extraordinarily rapid fashion. And the urgency, of course, is healthcare is a limited resource with limited specialists, and they are overwhelmed. Well, what about India? So I was in northern India a couple of weeks ago, and for those of you who spent time in India, sort of interesting cultural issues there. The patient owns the record. Now, I think all of us believe this is a great thing. I mean, right, we're seeing in the United States this new set of rules from our Medicare and Medicaid and our Office of National Coordinator of more data flowing to the patient's steward of their own medical record. Your phone will have all your lifetime longitudinal data. Well, in India, they've done this for years, except this is what the record looks like. And so that is a patient goes to see a doctor. The doctor, and don't worry, there's no privacy-related issues here. I actually asked this patient if I could show their record. You probably can't make it out anyway, right? It's like the doctor writes a few things, a prescription is written, and the patient and family is handed that piece of paper, and they carry it around, often in a little plastic bag. As well, if you have an x-ray, you're handed the x-ray. If you have a lab test, you're handed the lab test. So you carry and steward your medical care coordination for life. This is an example. I was in Bihar, which is in northern India, Patna and Bar, issues with poverty, pollution, a lack of access to care. So I was running a TB clinic in the streets. You can see here I've been asked to examine, looking for a little, what's at the apex, is this person a TB patient or no? So the challenge here is access to care. The right specialist at the right time. If you're in a rural setting, very difficult to get to that right specialist. So what are some of the digital transformations they're doing? So in this particular city, the per capita income is about $1 a day. There isn't sanitation, but there's 4G everywhere. And an Android phone is $35 on the street, right? So every family, not every person, but every family has an Android phone with good, cheap, ubiquitous bandwidth. And so what does that imply you can do? Even in a rural place like Bar, the Gates Foundation has funded some really interesting ideas. So imagine that in each village of 500 people, there's an entrepreneur. The entrepreneur, high school educated, is given an Internet of Things device for blood pressure, glucometer, pulse ox, and given the capacity over a 4G connection to transmit the data from the patient to a specialist in Delhi or some other city. So suddenly now you can do encounters even in rural areas by connecting the Internet of Things, the patients, their families, via phones to specialists, and for $1, you can get a teleconsultation. But there are some challenges of scalability, right? 1.3 billion people in India, 600,000 clinicians. So it is still a little hard. So what might you do? Well, this particular town I was in, I met a lovely 25-year-old woman, Pooja Kumari. Again, no problems. She's given me the opportunity to talk about her case. And she had a baby 6 months ago. And after that wonderful baby boy was born, she developed abdominal pain. She went from doctor to doctor, did telemedicine, that was all good, and never got relief of her abdominal pain. Hospitalization, it was assumed this was a postpartum infection or something physical was torn. She wasn't getting results. She paid over $1,000. Now, it doesn't sound like a lot in a US or Israeli healthcare system, but with a per capita income of $1 a day, she lost her cow, she lost her land, she lost her life savings getting the wrong medical care and no relief. So what do we do in this particular clinic is we ran a gene expert test for $10, and it turns out she had abdominal tuberculosis. Now, in Israel, you ever see a case of abdominal tuberculosis? I haven't in the US. Well, 60% of all TB in India is extrapulmonary. So who knew? So again, this concept of if you aggregate all the data, and you're now doing machine learning on that data, and say, oh, if it's January in northern India and abdominal pain is the sign or symptom, actually abdominal tuberculosis is in the differential. And so the challenge was, like so many doctors, we don't know what questions to ask for that patient in that setting, that geography at that time. And AI is going to help us. And so what the Gates Foundation would like to do is now begin sort of an MD clone-like approach of longitudinal aggregation of patient data across millions of patients with some machine learning components to help clinicians direct the patient to the right level of care and make sure we don't miss a diagnosis. Now, just to make sure there's a happy end of the story, we put Pooja on a fixed drug dose combination of TB medications, and I ran a GoFundMe and we bought her cow back. It's all good. So great outcome, bad process, need for digital transformation. Okay, sometimes, we were talking about memes. I actually searched for myself on the internet and I become a meme, which I don't know if that's good or bad, but I was in Norway dealing with their big data question. Now, if you spend time in the Nordics, very free flow of information, sharing of data, benefit of society and your healthcare, all beautifully coordinated, consistent privacy laws, national healthcare identifier, great stuff. They are asking the question, how do you de-identify the genome? Ooh, that's a little hard, right? I can aggregate data for big data and analytics and share it broadly, but the genome, And if you spill the genome, you can't exactly redact it, right? It's now out in the public forever. So their issues are not technology, it's politics. How do you come up with the right way to use the data for the benefit of all while protecting privacy? Finland passed a simple law. And that is, your data will be in the public forever for the benefit of the public, and there is no opt-out because the public is funding your health. How could you possibly deprive the public of the benefit of your healthcare experience? Now, maybe you can do this in Israel, but hey, Russ, try doing this in the US. Your data forever in the public for the benefit of all. It's not going to work so much. So I think we could take some lessons from our friends in Denmark, and Norway, Finland, and Sweden about the nature of data collection and sharing for population health and precision medicine as part of your moral obligation to society. You like that? Okay, this is Dudley. those of you who know me, I have a very large animal sanctuary that I run just west of Boston. Anytime an animal is abused or abandoned, comes to my animal sanctuary. We do all their medical care and nurse them back to health. Well, Dudley was 2,200 pounds, going to the slaughterhouse to be made into hamburger, and the Fidelity Investment Corporation, this very large financial services firm, decided they wanted a bull as a mascot. Not a bear, we don't have any bears, bulls. And this is Dudley living on our farm, Scottish Highland. So why do I show you Dudley? Scotland, let's talk about digital transformation in Scotland. See, you've already solved these problems, so you probably don't worry about this, but if in the United States, you were to go to an emergency department, Russ, and that physician was to try to deliver safe, quality, effective care, would they have access to your longitudinal lifeline record, every medication, problem, care plan, care team? Probably not. Yeah, I mean, it's getting better, right? But in the US, we're still a highly disconnected and fractured system. We don't have this national healthcare identifier. We have no capacity to very easily link together inpatient, outpatient, lab, pharmacy, urgent care across the United States. And 50 different sets of privacy laws make it hard too. Well, in Scotland, they put all the data for every single citizen into a single database for emergency care, and then gave every emergency practitioner access to that database. So that is, you show up for emergency care, I already know your problems, your meds, your allergies, your labs, and I can deliver much safer, cost-effective, quality care to you. So again, there's some lessons to be learned there, but we know there's still some challenges. About 50% of all the data in any electronic record in any country is unstructured, right? So it's text. And so they've built some advanced machine learning algorithms can look at the unstructured text and look for the major concepts that we might find in notes. And I love my colleagues in Scotland, but has anyone spent time in Glasgow? Glasgow, okay, well, anyone have any idea what the average alcohol consumption is per day in Glasgow? So it turns out it's 7 drams or 7 shots of whiskey per day on average. And so this database is being used to take a look at the social determinants of health that are recorded in unstructured data using AI to try to address the issue of alcohol abuse. So this notion of societal level aggregation, natural language processing, and AI for public health, precision medicine, is something they're doing fairly well. They only have 5 million people. I mean, once you have 5 or 8 million people, you can solve these problems. Now, Australia. So I was in Australia a couple of weeks ago, and for those of you who have spent time in Australia, they have done something quite good. The My Health Record product gives every patient full access to their lifetime health record over the internet, and we like that. What is the advanced technology standard that has been used in Australia? PDF. Yes, so they use digital paper. And so I met with their innovation authority, and they said, we have a goal. Double the number of fax machines by 2022, right? So their entire notion is that the electronic health record is just a simple digital paper transformation. And that, of course, is ridiculous, right? Can you search a PDF? Not really. Can you do big data analytics on PDF? Not really. Can you reconcile medications? Not really. So we hopefully, in this particular presentation in Australia, because Google was there with me, we embarrassed them enough that they're going to move away from fax machines and digital paper PDFs to structured databases and big data analytics with schemas that actually allow us to turn data into wisdom. So don't ever make the mistake of thinking that, as you said, simply digitizing existent workflow just gets you a bad result faster, right? Don't do it. Transform. And why do we all have to transform, as you said so eloquently yesterday and today? Well, across the world we have aging societies. Look at Japan. 26% of all Japanese are above the age of 65. Birth rates are dropping all over the world. Actually, I think they're still okay in Israel, though. But in Japan, 1.34, right? You're going to be 50,000 less Japanese by the end of the year, right? So if we're aging, and having more medical care and more costs, but have low birth rates and no one can pay for those medical costs, and no one's graduating into primary care, you're not going to be able to deliver the care to these aging societies. You're going to have a crisis. And so, politically, as a leader, I mean, there's just a few ways you can accomplish change, like pay people more or publicly embarrass them. But if you have an urgency to change, like society can't deliver care to an aging population, you must change. So Japan, for example, is going to change regulation. Right now in Japan, you actually can't use the internet for healthcare, right? The internet's basically a swamp of malfeasance and thieves. Well, I mean, that's probably true, but they don't use it for the exchange of data, and they don't use mobile apps for healthcare, and there's this fear of loss of privacy. So they recognize society will have to embrace the internet and mobile and aggregations of data if we're going to survive this crisis of aging, not only in Japan, but throughout the world. But there are challenges, and Russ, I'm sure in our panel we're going to discuss some of these. But let's talk about the Internet of Things, right? So all of us are now wearing IP-connected devices. Let's see, what am I wearing today? I beta test a lot of things, and this looks like an analog watch, but this is heart rate monitor, sleep sensor, looks at every movement that I have, transmits it to my phone, and that's great. And now we have doctors who in the United States are completely burned out, and they're overwhelmed, having 86 minutes a day of pajama time. That means they go home after dinner, finishing the medical records of the day. And I know we're going to now give them thousands of Internet of Things data points to review. How well is that going to work? And worse, do we know if this data is even of any value? I mean, what if, see, who's wearing a Fitbit? Fitbits? Okay, it's a fine product. But have you ever exercised and looked at your heart rate monitor from your Fitbit? Ooh, my heart rate's 20 right now. Well, no, you're sweating and the wristband is moving and the sensor's just not working so well. So what if, now at Mount Sinai you're getting all this Fitbit data and it shows people have heart rates of 20. Do you call an ambulance? What if you don't? Do you get sued? I don't know. And so we don't yet have a precedent, and maybe you guys are working on this, for what you do with Internet of Things data. Is it part of the legal medical record? Who has to review it? And what are the medical legal implications of reviewing it or not reviewing it? And we have to figure this out, because a Fitbit may be not so accurate, but if you had an implanted Medtronic sensor, and it said your heart rate was 20, you probably do call an ambulance. And this is maybe your idea of a control tower, a care traffic control facility that is looking at not only the electronic health record, but more things like Internet of Things, social determinants of health, patient-reported outcomes, and then making the interventions. So we also have this problem. I have 11 petabytes. How much do you guys have at Mount Sinai, do you think? Yeah. So with 11 petabytes of data, it's not the human scale to figure out, in the middle of the night, you're handed a 4,000-page digital chart. Care for this patient. And so the challenge of turning the data into action and wisdom is something we all face. And there are lots of startups working through this. So that is, a startup will create an AI system, looking at the chart, figuring out what the major concepts and problems are, doing alerts and reminders, and helping navigate that patient's care. Still have to work through that. We don't quite, from a precision medicine perspective, yet understand normal variation. So my resting heart rate is 45. Is that bad? I don't know. I have a 20-year-old who works on my farm whose resting heart rate is 100. Is that bad? I don't know, right? And so figuring out how, with all this new sets of data, that we figure out for that person when a material change needs an intervention still needs to be worked out. And across the world, we have security and privacy concerns. And as we talked about last night at dinner, I'm the second human sequenced in the Human Genome Project. And so 15 years ago, I gave up my right to privacy. I had to sign a 35-page consent that gave my genome every aspect of my stem cells and phenotype and labs and medical records and Internet of Things data to the public in perpetuity with no control. And for me, that was okay. but everybody has a different privacy preference. My mom, who's in her 80s, doesn't want to share her flu vaccine data, because that's personal. And so figuring out how we use more data for more purposes to the benefit of all while keeping privacy intact, still a hard problem. Again, you guys may have solved this, but in the US with 50 different states, try sending data from New Hampshire to Massachusetts and figuring out consent. Still a real challenge. Now, this conference will talk about tools, right? There's amazing emerging tools. So when I was a graduate student at MIT in the early 90s, machine learning was hard. It took a month to train a system. You had to write in Lisp. Anybody ever written in Lisp? Yeah, probably a few of us. To train the system that a giraffe was a mammal took a month. But now with things like TensorFlow, these publicly available cloud-hosted machine learning applications, you get 16-year-olds creating AI applications on a weekend, right? It's an amazing transformation in how easy it is to use these tools and technologies. So that's great. We, certainly in the US, and I don't know if you've seen this in Israel, that people sit at home on giant desktop computers with big screens and keyboards and interact with their healthcare system. No, this is the computing platform. And so people are embracing new workflows with apps that are giving them capacity to do anything on any device from anywhere. And that's becoming pretty mainstream. Do you guys at Sheba have an app store of some variety? So Beth Israel Deaconess, and does Mount Sinai have an app store? So the idea that there's 20,000 apps on iTunes. It's like most of them are garbage, right? So you do curated apps for patients and providers on a branded app store so that you can say, we've decided this is secure and good enough and relevant, and that's an emerging phenomenon. So our patients, for example, now can access about a dozen apps that we have written, some, Android and iOS, or curated the third-party products and said, these are good and fully interfaced to our systems. So that's becoming more ubiquitous. APIs. Now, for those of you who spend time in the standards world, anybody do standards? Oh, okay, so standards. Let's talk about standards real quick. There are forest folks and there are tree folks. Well, standards folks are bark people, right? We could spend a day talking about the relative value of a comma versus an ampersand. And the standards have not evolved very fast, right? But again, we are now seeing this era of APIs on provider data and payer data, government regulation enforcing data flows, patients getting fluid access to their data. So it's becoming more and more of an open ecosystem. And so, not that APIs will solve all problems, but it's a whole lot easier to use an API with an app than it is to use an XML parser, or to deal with HL7 version 2 and that kind of thing. So again, goodness is happening. And then I've been asked by several Israeli companies here, well, how do I sell into the United States? Well, remember, we're entering an era in the US where we're paying for value, paying for quality, paying for outcome. So actually, we want digital transformation because instead of being paid for heads and beds, as you said, full beds at Mount Sinai is a failure, that we're going to be paid for the fact that we're delivering care in your home, we're keeping you healthy, and we're not requiring you to have a hospitalization or a visit to one of our facilities. So that's a new economic driver. So all these are very good trends. What about machine learning, which I'm sure we'll hear from many, many speakers about, just as we talked about yesterday with ADOC. Is it going to replace doctors? Well, who knows, right? We can't predict the future, but I would tell you in the short term, it's augmenting our clinicians so that they work better, more efficiently, and practice at the top of their license. But also in some ways, it provides some guardrails. So let me give you a ridiculous but true example of what I mean. So I'm guessing for my MD colleagues and friends, you ever get family and friends that call you and ask, can you help me navigate the healthcare system? Yeah, unfortunately we get these calls every day. So I get this call, and don't worry, again, not a violation of privacy, a friend of a friend of a friend, not a family member, no one close, who just said, my daughter has been arrested at 3 a.m. in California running naked through a parking lot. Can you call the emergency physician and figure out what's going on? It's like, okay. So I call this emergency physician, and he said, oh, we just ran a tox screen on this 24-year-old woman, and we found cannabis. Yes. Now, I'm sure all of you know that it's very typical for any 24-year-old who ingests cannabis to run naked through parking lots at 3 in the morning. No, never, And so this emergency physician discharges her, saying, I've explained it all, because I knew this was a toxidrome, and I found it, decision made, gone. So immediately we flew her to Boston. It has one of those top 10 hospitals too. Picked her up at Logan, did a CTLP. She had 9,000 white cells, 0 RBCs. She had the worst case of meningitis any of us had ever seen. And we, of course, hospitalized her, and we got her back to health. And I asked her, what was this cannabis thing? And she said, oh, well, I had this photophobia and this headache, and I asked my roommate, do you have anything? And cannabis was the only thing they had in the house. I tell you this story because, again, if you think of machine learning looking at the cohort of millions of 20-year-olds who have altered mental status, will meningitis show up in that list? The answer is, sure. Is cannabis probably a leading cause? No. And this physician would have made a better assessment without jumping to conclusions with the benefit of millions of patients' experience. And that's where I think AI is going to really help. It's going to make us work more efficiently, and it's going to help us avoid some of these mistakes. A couple of just quick comments of BIDMC. So are we building AI systems that are going to replace doctors? No, we're building AI systems that perform workflow, digital transformation of the mundane. And what I mean by mundane, what OR schedule should we have given the limited number of ORs and lots of demand? Oh, well, if AI can tell you this patient only needs 25 minutes, this patient isn't really acute, and we can schedule more efficiently, suddenly we can use existing capacity in a much better way. Or how many patients won't show up to their outpatient appointment? Or how long should an inpatient stay for this patient really be? And suddenly we're starting to build Gantt charts for the flow of a patient through the system instead of the kind of Brownian motion random chance that happens today. So these are all done with Google and Amazon and collaborators with MIT, and they're all meant about improving our existing workflow as opposed to replacing a doctor. And the driver there is not necessarily cost reduction or existent resource use, it's actually meeting a need, transforming the system into something a patient would want. Well, some closing thoughts. So, although it is a bit depressing to be in the United States in the current administration, I did work for Bush for 4 years and Obama for 6, the current president not so much. 2019 has this beautiful convergence of these emerging technologies and urgency to change. Both CMS, our Medicare, Medicaid group, and our Office of National Coordinator have some intelligent regulations that are coming, and the private sector has a level of innovation like we've never seen before. We're starting to see the innovation nation and the startup economy fundamentally transforming the capacity of our IT systems, because we aren't necessarily waiting for Epic or Cerner or other products like that to innovate. We're actually getting these third-party products and adding them on top of the existing electronic health record. As you say, the focus of digital transformation isn't the electronic health record, it's the stuff around it. So I feel very positive and optimistic. And I really do feel that the private sector is going to be the catalyst for 2019 and 2020. Pretty clear the technology is mature. The technology is good enough. I mean, this is not Theranos, right? That these AI systems we're talking about, they work, they're real. It's just a question of getting them in place and using them across our various provider organizations. The API standards are maturing, not perfect. Still work to do on expanding the number of data elements and the semantics and social determinants of health, but every year they get better and better. I guess last thought is, and this is where I give you the challenge, You know, some of us are providers in this room and data scientists, but we're all patients. And if we are going to navigate all of that healthcare in the future for our families, for us, for wives, for parents, for children, we do need better tools. And so I think that getting those better tools throughout the healthcare systems of the world depends upon you. And I think that's the subject of this conference. If we can come out of this with a to-do list of what those tools will be, and I look forward to implementing them in the United States, because we are very close to Israel, and we want to see your product succeed worldwide. So thanks so much, and I look forward to the panel.